Welcome to BW Healthcare World. The topic of discussion today is vision as known by a visionary. My guest today is Dr. Mahipal Singh Sachdev, who is the founder and chairperson of the Center for Sight Group of Eye Hospitals, someone who successfully institutionalized eye care in India. He's a pioneer of stitchless cataract surgery in India and was awarded with Padma for the contribution in the field of eye care. Dr. Mahipal, welcome to BW Healthcare World. Thank you so much for taking out time. My first question to you is a very basic one. When you were practicing, there were these large hospitals which had eye departments, and people were used to going to a hospital to get their consultations and treatment. But you chose to set up specialty centers. In fact, you were the first one to institutionalize eye care as a hospital. So how would you compare specialty centers versus the multi-speciality hospitals in terms of care and the facilities?
So thank you very much in the first instance for having me. As regards your question, yes, I have worked almost all my life before I ventured into starting Center for Sight in big hospitals, being a graduate, a postgraduate, and then a faculty of All India Institute of Medical Sciences, having spent 20 years and then having joined Indraprastha Apollo right from its conception in 1996. The journey or the thought process started from the fact that if you look at multi-specialities versus single specialities are now coming of age, and it is not just in eye care or ophthalmology, but you can see IVF, dental, dialysis, etc., skin, hair transplant, because these things are coming as single specialty. Now, the main thing is for any specialty or any service to succeed, there needs to be a focus. Now, when a person goes into a multi-speciality hospital, their focus is on number of beds. So even if they have money spent or investments coming in, the return on capital is considered on per bed return on capital as to what they are spending per bed and as to what is the capital return that they are getting from the bed. Now, obviously, these specialities are considered to be just fill-ups or fillers, and they are kind of me-too products within the entire armamentarium of the multi-speciality hospital. The second important thing that is there is that if you look at single specialty, except maybe for dialysis, majority of whether it's cosmetology, IVF, etc., that's something about life. It's something about a person not being sick or ill. Even when we are talking about, say, eye care, if you're talking about a person getting a cataract surgery done or a laser vision correction done, the patient is otherwise not sick. So the concept of a person going for sickness to a hospital is kind of slightly different in a single specialty, where a person goes for restoration of something or enhancement of something. So the mindset is rather of a daycare or a quick service kind of a thing. It's more like, if I would comment, say, if you go to a multi-cuisine restaurant or you go to a fast food where they are specializing in doing the same thing over and over again. So there are two advantages that come to it. One is the repetitive nature of the same thing that is being done, and the investment that you make into making those repetitions more standardized is much more in single specialty. And the second thing is that obviously, if you are repeating the same thing over and over, economies of scale come in, and the kind of money that you need goes down. So that is why the single specialty is there to stay. If you look at globally, also single specialties are in ophthalmology. If you look at the oldest names, it was in Chennai, which was more than a century ago that you had the first eye center. Then if you look at Moorfields Eye Center, or even if you look at Mass General Hospital, within Mass General Hospital, there is a Mass Eye and Ear Infirmary. Okay, and because eye and ENT were one specialty maybe about 60 years ago. So the focus is the key driver for single specialties, for giving better service, better technology, better skill sets, quicker turnaround, and not having the patients in a sick world. Having patients who are you don't have people lying on a stretcher, or you don't have people with IV sets, or people kind of having broken bones and things like that, which you will see in a multi-speciality. So that is the key driver for single speciality. And nowhere in India also, if you look, a multi-speciality hospital has nowhere succeeded in putting up a great ophthalmology department, or say even an IVF. So you just look around any of these, not even a single big specialty chain, and they outsource ophthalmology because they say, "Theek hai bhai, that is not our core area. Let us go ahead and just outsource it." So that is why single specialty has come of age. The maximum interest, if you look at eye care today, there have been close to about 30 private equity investments in eye care over the last 5 to 6 years. So I think this is something that, as I said earlier, has come of age, and it's going to only increase in size, in numbers, and in penetration within India and overseas.
I completely understand, and that how the specialty centers are doing a more focused job. In today's day and age, when healthcare is not just about getting the treatment or getting a procedure done, it's also about the experience. And when I look at a specialty center, I understand that the experience is slightly better because you're not surrounded by sick people around you. That's one. But does it also impact the affordability of the treatment as well?
Certainly, it impacts the affordability because, see, the systems that are set in hospitals are basis bigger surgeries or bigger things like that. So, for example, when I was in Apollo, there used to be a separate room rent. There used to be a separate OT charge, which used to be for every 20 minutes of OT that you are using. There used to be an assistant charge and those kind of things. So, what happens is that when we are working in single specialty, we give packages. So it is a package that the patient is aware of beforehand. There are rarely escalations, which is the common kind of friction point between a patient when a patient is getting discharged and things like that. So we kind of have these rolled up into a package. And also, God forbid, if there is something that goes wrong within the surgery and we have to do an additional step, etc., we rarely charge anything extra from the patient. So therefore, the patient, once, as regards the experience, it's a quick turnover. That is the other thing. And a lot of hospitals don't even have a daycare facility to that extent, or a facility where there can be a good churn. Now, I'll just give you an example. I used to work in Apollo, and every day in the morning when I was supposed to start my OT at about 8:39, that's been my schedule, 8:30 was my OT time. And the patient would have to come around 5:30 in the morning, right? To get admitted, to get into the ward, whether it's a general ward, a private ward, bed is available, not available, etc., etc. And then I would get a call from the OT nurse without fail, despite having told, "Sir, iska blood group nahi hua hai." So iska blood group karwana hai. Blood group is now a non-essential thing because we don't bleed in ophthalmology. It's a bloodless surgery, etc. But because there were the SOPs of a hospital that anybody going into an OR or an OT needs a blood group, that happens. So therefore, we are able to cut out the bells and whistles or the things which are SOPs for multi-speciality and which add on to the costs. After all, if a patient is going into a bed, like if you're going into a hotel room, even if you want to freshen up and you take a hotel room, they will still charge you for a day. So that is not what we do. My patients come in at, say, now instead of 5:30 in my own center, they will come in at 7:38 and they are out by 10:30 period. And the first patient starts to get out by 9:15. So the cost obviously go down because I don't have to buy infrastructure. After all, there is a room rental, there is a space, there is a lease, etc. So that gets cuts out. You don't have a wheeling in for a patient from 5th floor going on to another floor. So costs are definitely packaged to suit the pocket of various sections of society. And the costs are definitely lower in a single specialty as compared to this thing. And there are no surprises. That is the most important thing. In, say, a multi-speciality, supposing a patient had a problem in surgery, post-op a patient comes to me with say a X problem, and I need to go back to the OR, I will have to pay the charges within a multi-speciality hospital for taking that patient back to an OR. But our systems within ophthalmology are that, okay, fine, if we have done a surgery, we have promised or we have said that this should be a result. And if there is something that basically doesn't go the way it is supposed to go, then in case there is a second intervention required, I don't, the head center for sight have additional charges. So packages, if you look across the board, whether with the problems, without problems, with the patient affording, not affording, etc., you can have much lower packages and no surprises.
So if I understand correctly, there are three things that are impacting. One is that there is no additional infrastructure cost, which is unnecessary for the procedure.
Yes.
Second is that, you are paying for an outcome and not for various things that are required for that outcome. And third is that there is predictability. So there is no surprises and shocks later. So you know what you're paying for and you know what you will be paying.
Yes.
Right. Dr. Mahipal, you recently, a few years ago, you had Mahindra collaboration. Can you tell us a little bit more about this? I think it happened around 2019, if I'm correct. And soon after the pandemic hit us.
Yes.
And so obviously all the elective surgeries, etc., the business had gone down. How has been the journey and what are we expecting further as a growth strategy for an eye care hospital chain?
Okay, so you're absolutely right. We did get an investment of over 200 crores from Mahindra Partners. That is a direct arm from Mahindra and Mahindra. And that was in end of April or first week of May of 2019. And as you know, that the pandemic came in. So yes, we had experience with private equity. We had 2 rounds of investment earlier with Matrix Partners, and they got an exit, and Mahindra Partners came in. So the experience, obviously, right from the beginning, has been of a supportive role. Of these people have a bird's eye view, or I would say a 30,000 feet view of how businesses are run and how to scale up businesses and how to improve these services, etc., etc. And they have support. Say they built up logistics, they built up computers, Tech Mahindra, etc. So there are various ancillaries that come in from their experience pool to help us grow. And see, when you are an entrepreneur, you are focused on certain things. Obviously, unfortunately, the biggest thing is that in Medicare or in MBBS or MD, there are no lectures or there are no teachings about business administration or management, etc. And we are homegrown kind of entrepreneurs, reading and those kind of things, and making to see that the business grows. But then these people bring in a lot of those capabilities, which actually help you broaden your horizon. And that is the best learning that you have. And apart from that, obviously, there is the power of financial power that is there, which is obviously the catalyst for growth. So those are the things that is, unfortunately, you are absolutely right. We are an asset-light model, and all our properties across 13, 14 states that we are in and 60 plus centers that we have are rented properties, except for one, our super hub that is in Dwarka, which is a purchased property, but that also has a lease rental with Dwarka, with the DDA. So we had to pay those rentals. We talked to the landlords, etc., and those kind of things, but still there was only X percentage reduction in rental. And then elective surgeries were gone for a 6. The salaries had to be paid. There was a fixed cost, etc., etc. And that was a big problem because we deal significantly also with the geriatric population. And geriatric population was being said to be the most vulnerable, and they were the most vulnerable for the morbidity and mortality of COVID that was striking the country at that time. So yes, we did have difficult times, but fortunately, being a debt-free company, and we were able to weather it. And even in that year, we didn't go in the red, and we were able to be in the black, because the surgeries came back. And they came back with a vengeance. Like now, a person has to get a cataract. So a person will get a cataract done, if not today, tomorrow. And that is what happened. The pool was there, it got swollen, and then it came back to us. We were doing emergency surgeries at that time, retinal detachments, vitreous hemorrhage, things like that, macular swelling, etc. Those kind of infections, trauma, etc. Those were the things. But yes, it was a tough time for all of us, and I hope that it is behind us, though nobody knows that whether it is behind us or not. But yes, there are certain spin-offs that have happened, though that is not a direct question that you have, but there are certain spin-offs that have happened, that lot of mindset change has happened in the entire population, and so be it within ophthalmologists. And we have, all of us have realized that we are all perishable commodities, and lot of people or lot of ophthalmologists who do not have follow-ups. That means that their children are not there into the same business, or they are gone overseas, or from a smaller town they are migrating to a bigger town, are now willing to collaborate and sell their practices rather than take it to the grave with them. So that consolidation, it has really triggered consolidation. And if today I approach 10 people for a merger, I would say 20 to 30% are willing to do that. While what I started way back in 2009 or 10, I didn't meet too much of success because people were saying we lose our freedom, etc., etc. So what is today a given, say in US, that everybody after a particular age would sell their practice, we are having the same thing that is happening in India today in the field of ophthalmology, and it's mainly in ophthalmology. These kind of diagnostics, there are big mergers that are happening and small, but ophthalmology is we are leading the pack with these mergers and acquisitions. Mahindra are with us. They are great. It's a great name to be associated with, having a personal rapport with Anand. I think, again, somebody who is a big name and has a great horizon for his thought process and handing over the baton to the next professionals to manage the company, etc. I think a lot of good things have come with our collaboration with Mahindra.
Awesome. So the growth is going to come typically from M&A activity. That is.
Sorry, I missed the second part. Yes, the growth is going to come from 2-3 concepts. The first concept is same center growth. That means the same center, or when you talk to private equity, they call it same store, but I prefer to call it same hospital or same center growth. So in the same center growth, we divide ourselves into new centers, semi-mature and mature centers. So when you're looking at mature centers which have been there for more than 5 to 6 years, the growth slows down to the extent of about 10% to 12%, which is reasonably a high growth. And half of that growth comes from volume, and half of them comes from procedure upgradation. One thing that is happening in ophthalmology or in healthcare is the tech coming in, the new equipment coming in, and new technologies leading to higher payouts by the patient. So that is where your growth is going to come. Then the second part of the growth is going to come from new centers that you open as greenfields. And that obviously has its gestation period. Typically, it's 18 months to 3 years before we break even. And that's much, much shorter than what you do for a multi-speciality. The third growth is going to come from acquisitions or mergers and acquisition, which I think is going to become bigger and will play a bigger role. Because if you look at other eye care chains, except for us and maybe one more, they are all minority holders today. There are big private equity players for the other chains, where you can look at TPG or Temasek, or you can look at GA, Kedara, etc., or IFC, etc. They are all majority owned by private equity. So therefore, private equities over time is going to go for consolidation. So even small consolidations and bigger consolidations are going to happen. And the last thing that is going to drive the growth is upstream, downstream. That means using, say, for example, ancillaries. There are 3 ancillaries as things stand. One is opticals, second is pharmacy, and third is what is you say is diagnostics. So these are going to be used to garner growth, for which we were possibly not concentrating to that effect. So I think these are going to be the growth drivers over the next decade, I would say. And I would personally feel that the other growth driver would be tech coming in, artificial intelligence, machine learning, etc., and more robotics coming into eye care, and that's going to drive growth.
Sir, we compared a hospital with a specialty center.
Yes.
What is the future of the standalone clinics which the doctors have?
I think the barrier to entry has gone up significantly. So there are less and less of new postgraduates who are opting to start their own. So that is a given that there is a significant penetration just now of these ophthalmic chains into various cities. And we have the manpower. The lot of people are even selling their practices because they don't want the hassles of administration. Unfortunately, as healthcare is coming in, as managed healthcare is coming in, the paperwork or the administrative hassles, the recovery time is going up. You might have read in the newspapers about CGHS not paying, they not paying. So the younger people or the people who start do not have the muscle power to withhold those things, because see what happens. Let me give you an example. You come as a CGHS beneficiary or XYZ beneficiary. You just get me a paper on which there is a permission. I do the surgery for you. I have spent on the consumables. I have spent on manpower, time, etc., etc. And then on the mercantile system, I have also paid tax on that money. Okay, so it's a double whammy or a triple whammy, and that money is stuck for 2 years or 3 years. So the economies doctors are supposed to be making an obnoxious amount of money. I don't think that is correct. The EBITDA margins are not great for multi-specialty. We are much better than them, but again, they are not great or comparable to other industries. So that is the first thing, that the money power is not going to be there. The second is barrier to entry has gone up. When we were, say, MBBS student, all you needed was a torch. And you could go to a camp, or when even before our times, cataract surgeries were done on railway stations. So today you need a femtocataract, you need a microscope. So the whole contraption, you need a phaco machine. So you would require, say, maybe a setup of 10 crores. So that every person or an ophthalmologist who was coming out was thinking of setting up a practice. That barrier to entry has gone up, and it went up for a cardiac surgeon or a neurosurgeon several years ago. But in ophthalmology, now it's going up. So, and there is the constant upgradation that is required. And a single practice cannot do the upgradation that is required, and all of that needs money power. So what I feel is that ultimately what I said was consolidation. Less people are going to start their own, and all these clearances have become hell. You had certain fires, etc. So you have a fire clearance, you have administrative clearance, you have residential, commercial area, this, that, and the other. And unfortunately, the bureaucracy or the Indian system does not move fast. There are no separate rules for daycare centers. We are daycare centers, and the rules for multi-speciality hospital for a fire clearance and for a dental or an ophthalmology is the same. So, we are not that strong to lobby, etc., though we are trying to lobby it, things like that. So it is going to be hell or very difficult for individual practices to survive. And a lot of practices have shut down, not in ophthalmology to that extent, but in small nursing homes. So the same is going to happen. There has to be corporatization. There will be standardization. Once there is standardization, there will be some amount of commoditization. And that is something that is going to be driving the future of this thing. If you look at, I'll give you the example of the most successful listed company in ophthalmology, that is called as Ayer. And that's in China. I don't know what its valuation today is, but it was close to 30 billion US dollars. And that does take care of 10% of China's eye care. 10% of China's eye care is run by one single company. And even if you look at Arvind eye care system in Tamil Nadu, every sixth cataract that is being done in Tamil Nadu is being done by Arvind Eye Care. So you can understand the phenomenal growth of chains or corporatization, etc., that has happened. And that is going to make people. And now the other important thing is, because there is a lot of investment that is coming into ophthalmology, there are more centers that are being opened. Because there are more centers, people are getting more jobs. And these jobs are at higher paid because there is competition. So a person who was being exploited earlier by a NGO or somebody to get, say, 30,000 rupees as a salary is today maybe getting 3 lakhs. So he is satisfied. He can have a good standard of living, etc. So why break your head and do brain damage to try and set up something where you may or may not succeed? So that is what I feel, that these standalone practices will be there. People will come out and they will be entrepreneurs and they may become chains, etc. But ultimately, the numbers are going to go down.
So you use this word entrepreneur. So my next question is related to that. Do you think every doctor needs to learn to be an entrepreneur to ensure that the services are provided in a sustainable manner? I mean, while every person expects a doctor to be, provide the goodness, etc. But at the end of the day, like you just mentioned, there could be an investment of 10 crore rupees in an infrastructure equipment in just one center. Entrepreneurship has been a word among healthcare practitioners that seems to be a taboo. A few years ago, if you'd speak to a doctor and tell him that, you are doing a business, so he would take an offense to it. But Center for Sight would not have been where it is had you not had the entrepreneurial mindset. So how did you marry entrepreneurship along with being of service to humanity?
Okay, so there are two things that I normally say: being an entrepreneur, passion and ambition. These are the combination of two things that you need to be passionate about what you're doing. I love what I'm doing. I loved surgery. I love to give results to the people, etc. But I was also ambitious in making things grow. And once you are making things grow, you need to talk about the business side of the whole thing as to what is sustainability. If I tell a doctor today, maybe 10 years ago or 15 years ago, they wouldn't know what an EBITDA is. They wouldn't know what a ROCE is. And they would buy equipment without actually looking at whether there's a return in capital or etc. and what is the utility that's there. So that mindset is changing. Entrepreneurship is coming, and you have big people who have to. And the point is, if you can't be an entrepreneur yourself, you get the team to help you become understand the business sense. And there was a clear cut saying that everybody says is that until, of course, you understand the business of the entire thing, you cannot grow. So you will need to be entrepreneurial. You will either have to get people, give them ESOPs, etc., to actually run the business side of it. So that is something which is absolutely a given, that one has to look at it from that perspective. And the second thing that I'll wish to say is ambition and passion is what I said. And the second thing is good money and bad money. So good money and bad money is something that needs to be differentiated. And I am very clear and I am very focused. Ethical, honest, clinical opinion is good money. Bad money is dishonesty, making a fool of the patient or doing something which is incorrect. So there is nothing wrong in making good money. If an MF Hussain can sell for 5 crores, after all, for every surgery that we do, we kind of autograph it or sign it that this surgery has gone through my hands, etc. So fine, I have no issues in saying that this surgeon, if he's wanting to charge an extra this thing, it's a listed charge, and it's a good money. You are delivering the services that you are doing. You are honestly doing that, and that is what pays you in the long state. So these are the two things that, so there is no shame if you are doing the business and that business is also serving humanity. It is not that I am doing a voyeuristic kind of a pleasurable or something like that, or किसी को मतलब गलत शौक के तरफ ले जा रहे हैं. It is something that a person needs. And even if you are doing it, so let's give a very lower example of, say, an urban clap that is doing today. You need a plumber. Anybody could exploit. So that was bad money. That theek hai, plumber aa raha hai, usne, something was not required. He will say, okay, you do this, do that. But then there is a standardization that has happened, and you prefer to go to those people. So similarly, I don't think there is anything wrong in saying, because someone has to pay for the services. That is the mindset that has to change within the country. Unfortunately, that is slowly coming in with these insurances, etc. But then there is a constant struggle that is happening. What a TPA or an insurance used to pay me a decade ago, they are still paying me the same. So that is not happening. They want to bring down the prices, and obviously the cost, infrastructure, salaries, everything is going up. We are not able to get that. So that is something that obviously will keep on going. That is part of life. But I would say nothing. If you have to give better services, you can see what the public sector or the government sector is, where it is. It is in, I don't know whether to use the word shambles or whatever it is. But today, when I was in All India Institute of Medical Sciences, that was the first place to get technology. Today, they are not the first people to get technology, because things have opened up. There are more people who have made good money out of it, who are willing to make investments. So the population is benefiting from it. You are giving them better care. You are giving them standardized outcomes. You are giving them something in which you are accountable. There was no accountability, or there is still very little accountability in the government servant as regards government service as regards the outcome as it is, because we are taken to consumer courts, we are this thing, etc. Anything can happen. So all that I am trying to say is, I don't think that what you said was right, but it's no more applicable 15 years, 20 years down the line. A doctor would be, and I think the first person I had the privilege to work with, Dr. Pratap Reddy. I think he is the person who was I would say, the first person to bring in corporatization or standardization of healthcare and touching lives and bringing service to the Indian population that needs in healthcare.
Absolutely. I think you brought up a very brilliant point that, one, people must understand it is a profession. And if there is a quality of service, it comes with the quality of equipment and the quality of manpower, and that needs to be respected, and somebody needs to pay for it. You brought in the word passion and ambition, right? So I'm going to speak to you about passion. Do you think entrepreneurship grows with personal passion? I'm sure you agree with it. But doing things by yourself, or you believe that teams and collaborations play a larger and more important role? What would you share with young doctors who wish to become healthcare entrepreneurs based on your personal experience?
So I think again, Panch Ungliyan fist, that is the simplest example. The power of the fist is always more. And right from the beginning, my intent, since you are asking my personal story, was to get super specialists. And I got out 3 to 4 top of the super specialists from eye care from All India Institute of Medical Sciences, who were all of them were what we call blue-blooded Amesonians. Means they were AIMS graduates, AIMS postgraduates, AIMS faculty, and I getting them out of a AIMS job. When I was leaving, my parents would say, "You are stupid because you became a faculty at such a young age. You will become director or something like that." But that wasn't my calling. So the first and the most important thing is to build a team, and together we will succeed. That was my motto right from the beginning, because you need to be considered the last word in something. So I would say that when the no-stitch cataract surgery, phacoemulsification came into the country, I was one of the pioneers in that, and then refractive surgery for removal glasses. So, and I was a cornea surgeon. So cornea has fallen by the wayside over time, but cataract and refractive surgery, if people need to get their eyes operated, etc., ophthalmologists, their relatives, etc., they would come to me. But that was not the case if I needed to look at a patient of glaucoma, or that was not the case if I needed to look at a patient of retina or a patient of trauma. So you needed to have people who were more brilliant than you and not a Me Too product in that particular specialty. So that is the concept on which Center for Sight existed, is existing. It was started, was that the skill, the manpower, the super specialization, the brilliance of people needed to be recognized. As over time, I would say maybe commoditization, standardization may happen, but in those times and even today, as this is the only profession where as you age, your vintage, or maybe wine, your vintage goes up and you become more expensive and things like that. So that is where, and the longevity of a surgeon is still much longer than in other professions. So that was the thing that, yes, making a team. Then I brought in corporatization in the sense that I got people from Bosch and Lomb, I got people from J&J, I got people from Fortis, etc., etc. So to bring in these systems. So both of these things are needed. I got a CFO from GE Capital. So those are the things that you need, and you need to, and as they say, you give peanuts, you get monkeys. So you need to spend money. You need to have brilliant guys, and one suggestion, two suggestions can actually be path breaking at times and do that. So those are the important things that you have, and you need to build up a team. Growth is something that needs to be essential, and those people whom you bring about with you should talk quality, service, and growth.
So, do you think that medical education needs
Yes.
to now start including practice management and skills of entrepreneurship as a part of the curriculum?
See, I said that, and I still believe that should be a primer. There will be people who will do MBBS and they will go into management. So there are courses post MBBS into management. So they are going to run the processes, they are going to run the operations, etc. There will be other people who will do business development, etc. But as a doctor, you need to be primed. You need your thought process, your horizon of thought needs to improve. You should not be the typical mentality of somebody being in a water tank or being something and thinking that this is the entire, or in a well and thinking that this is the entire universe and the world. The world and the universe are much bigger. So you will need to have primers. You need to know about practice management. You need to know about money being spent. You need to know about return on capital, EBITDA, etc., break evens, those kind of things. That needs to be done. And then you need to also be told about management, where you should be talked about team building exercises, getting a team together, putting everybody and making those people. So again, there is something that I say, that if you are the brightest kid or the brightest person in that room, then your organization is not good. You need to have people brighter than you in the room within your organization. And for that, your thinking needs to be primed that मैं ही मैं नहीं हूँ, हम ही हम होना चाहिए.
I think that's a very brilliant thing that you've said, because that requires a mindset shift. That's not something that can be just taught in a classroom. Dr. Sachdev, I've asked you about how you've grown Center for Sight. What are your thoughts on entrepreneurship and healthcare practice? Now, it'll be unfair to the audience if I don't ask you things which are your core specialty.
Mm-hmm.
So I would like to ask you a few questions around eye care.
Mm-hmm.
Do you think everyone is bound to have cataract in their lifetime? Is it that everyone will get it?
Yes, given a long enough life, all of us will develop a cataract. Just to simply put it, there is, as things stand today, despite Ayurveda and homeopath and people saying that there are drops which can stop the progression or reverse the progression of cataract, there is no such thing. As we can't defy aging, similarly, this is aging of the normal crystalline lens within your eye. There is a crystalline lens within your eye, like in a camera, you have a focusing lens. Similarly, there is a lens behind the cornea and the brown of the eye, which is the focusing mechanism of the eye, which is transparent and which is clear. Now, as you age, like your hair go gray, similarly, the proteins become clumpy within the lens and they become too opaque. They turn opaque. So there is an opacification of the lens, and there is nothing that can prevent this, whether it is UV light exposure, sun rays, episodes of diarrhea, dehydration, metabolic changes in diabetes, etc. There can be X amount of multifactorial, but the basic point is all of us will age and the lens will also age. So once the lens starts to age, it becomes clumpy, it becomes cloudy, and because you cannot reverse this process as things stand today, you will have to undergo a cataract surgery. You have to remove this lens and replace it by an artificial lens. So the one line answer, given a long enough life, all of us will develop cataracts. And just one more thing to tell you, people may not be aware, there are children who can be born with cataracts. So there can be congenital or developmental cataracts, and younger age there could be traumatic cataracts. Abhi, unfortunately, ये तीर कमान का season आएगा, that can increase the number of perforating injuries, industrial injuries, which can cause cataract. So you can have cataract starting from birth, going up to the old age. And India, unfortunately, is again like they call diabetic capital of the world. We are also the cataract capital of the world. We in India do about 75 to 80 lakh surgeries a year, which is equal to the number of surgeries done in US, Europe, and China put together.
Got it. Got it. Is there a certain age when typically a person expects to?
Yeah, so basically there are the diseases of aging are catching up with the eye also. And cataract typically tends to happen after 50 years of age. In India, it happens about 10 years earlier. In the US, it's maybe 60 years plus. In India, it's about 50 years plus. You can tend to have a cataract, and then you need a surgery. Glaucoma is also age-related, diabetic retinopathy, longevity of diabetes, age-related macular degeneration. So there are X number of diseases that are coming in with the increase in longevity of an individual, which are affecting the eyes.
Right. Dr. Sachdev, how has technology changed the way people get treated for common disorders that appear in the eye? And what is the digital transformation at Center for Sight in your vision?
So one is, how has technology changed? So let me just, you asked about cataract, let me just go back to cataract. The first cataract surgery that has been described is described out of India, and that is by Shushruth. So Shushruth used a lancet kind of a thing, put it into the eye, and the cataract is something that in the right behind the pupil, there is the lens which becomes opaque. So he would cut the attachment and just throw the lens back. And the pupil would get clear, but then the person focusing power or the power goes down. So person would need those thick soda water glasses, that's a +10 number, etc., etc. So in cataract today, from that day to people being in sandbags, when the incisions became large and the cataract was taken out and people had to be put into sandbags and not move their head, etc. From there, it has become a topical, no stitch, no bandage, walk-in, walk-out procedure, no injection kind of a situation. So the technology has improved to robotics there. So you have a femto laser today. There is an image that comes of the lens. And today they are getting an artificial intelligence into that, as to the picture of the lens is going to grade the type of lens opacity that is there. And then the amount of laser delivery of the power and how it is going to cut is going to be decided. So that is this thing. And then you do a couple of steps, you liquefy the cataract and you take it out and replace it by an artificial lens. That's an intraocular lens. So optics, space age, aberration profiles, achromaticity, asphericity, these things were not talked about in lenses. So these are quality of things that are improving, and there is a marriage of all those things that is happening. So technology has evolved. Today, I may be not able to count the number of lasers, but there are at least 15 to 20 different types of lasers that are being used within ophthalmology to take care of various diseases of the eye. Every laser has a different wavelength, and that wavelength does a different action. So there is high tech that has come in, Space Force, lasers, etc. All those things have been put into technology, and this is something which is improving. Now let's say what is going to happen in future. I foresee a person going to a mall. There is a machine that is sitting there which can take pictures of your eye. You just go there, take a, like you can have a weighing machine or whatever it is, or like nowadays you're going into the check your temperature, etc. They'll take a picture of your eye. The eye is the only place where you can see the blood vessels of an individual. So आपके दिल की नाड़ियों के लिए you will have to do an angiography or whatever it is, but here you can just take a picture and see what is the inside of the eye and what the vessels are. Tomorrow, your diabetes profile, your hypertension profile, your chances of getting a cardiac event, etc., can be through artificial intelligence and through these nomograms, etc., and through these pictures, will be able to diagnose and establish that this is what it is. Similarly, it is going to do the same for cataracts. Like teleophthalmology was the biggest upside or the uptick in during the COVID times, because you could possibly send small gadgets to individuals, and there's a lot of work that is going on which could take the pictures of the eye. That is the biggest advantage. Majority of the parts of the eye are available to photography and then treatment. So therefore, that is where digitization, tech, those kind of things, artificial intelligence are going to come and be transformative in ophthalmology. So that is going to be glass prescriptions. As you know, there are auto refs now. Earlier we used to do retinoscopy, etc. So lenses being made even to the power of 0.12, etc., customized to your eye. Those are the things. So optics is going to grow. Nanotechnology is going to grow for targeted medicines, etc., for targeted lasers, etc. Things are going to grow, and diagnostics through optics and through artificial intelligence is going to grow in ophthalmology. And I think we'll have to assimilate it as Center for Sight as being pioneers in technology, etc. And we are doing work on it. And obviously, that's a different domain and would require a lot of money onto it. But that is something that's going to come into ophthalmology. Was considered to be a poor man's specialty. And when I said to my would-be wife that I'm thinking of taking ophthalmology, she said, "Bhukhe maroge." So the transformation that has happened has been phenomenal, and technology has come into, say, radiology, it has come into cardiac, but in ophthalmology, I think it's really galloping at a pace where things are going to work much better.
No, I think you have not just disrupted the space, the practice, but also disrupted technology. And I could only imagine when you were speaking about the future and what it would look like. And I think personalization is going to be the key when we look at the future. Now, you sir mentioned about diabetics and India being the diabetic capital, and cataract is also really big. Diabetics usually develop problems related to eyesight. What are the things that people need to take care of as a precaution, specifically for ensuring that they are able to maintain their eyesight?
So actually, the biggest problem in diabetes is ignorance. Majority of the diabetics don't even understand that diabetic retinopathy or diabetic eye disease is the leading cause of blindness in the most developed countries. In India, it's still cataract, but given again a long enough time that diabetes has been with you, given hypertension, smoking, cholesterol or lipid profile, etc., these things cause vascular changes within the eye. As they happen elsewhere for the kidney, for the heart, etc., and the vessels become leaky and they bleed and they are friable, etc. So diabetic eye disease needs to be controlled. Once you have it, it's fine. You can do lasers and injections, etc., to control it. But the earlier detection is something which is very, very important, which because of ignorance, people don't. So the moment you know that you are diabetic, or even if you don't know, I think an annual eye checkup is required. And if you are diabetic, it needs to go down. And if you have diabetic retinopathy, then you need to have a 3-monthly checkup. So between 3 months to 1 year is the checkup that is required. And if we are able to diagnose early the onset of diabetic retinopathy, that will be great for stalling the progress of diabetic retinopathy. So diabetic eye disease is a bad thing to have, and unfortunately, association of diabetes and the length of diabetes that a person has and the control of diabetes, etc., and the time at which the intervention is done are going to be deciders. So people should know that you need to get your eyes checked up if you have diabetes.
Right. So since you spoke about eye checkup, there's a question that comes into my mind. I wear specs. Now, when we typically go for an eye checkup for the purpose of getting your spectacles, we typically go to an optician and get an eye checkup there. Now, what is the right place and what is the right eye checkup?
So basically, see, the problem is that I'm not saying that the optometrists do not, they have a very big role to play as paramedics and as people who help and as in dispensing of glasses. But unfortunately, they are not trained enough to do a retina checkup, or they're not trained enough to look at diseases of the eye, nor are they allowed to prescribe medicines. So ideally, once a year, you need to go to an eye specialist, and you need to get an eye checkup done. And in case you break your glasses or you want a different kind of a frame, etc., then you could go to an optician. But an annual eye checkup is something that is very, very important. And the people need to differentiate between, like you have quacks, you similarly have at times optometrists in smaller towns and cities being called as doctors. That just needs to be taken care of. The optometrists have a very significant and a great function to play because today the maximum number of patients having visual impairment are patients who don't wear glasses. So they will give glasses, which is a very good thing. But ultimately, I think for diseases of the eye, apart from refractive error and contact lens fitting, which is the domain of the optometrist also, we should go for an annual eye checkup. You need to, like, if you are a high myope, as possibly I can see, then you need to get a retina checkup for retinal degeneration, etc., diabetic retinopathy. So those are that differentiation has to be there.
So use of gadgets is on a rise, and kids have taken on to gadgets during pandemic as gadgets became a utility item for them. It was needed for their studies, continual education, etc. What is it that children need to do to ensure that they don't harm their eyesight using these gadgets? Are there any precautions that the parents can push the child to take care?
So there are a couple of things that you need to remember, which are universal global truths, that the incidence of myopia is going up. That means the people needing minus glasses is going up. And why is that? The eye is basically made for distance vision. You are looking at distance, you play outdoor games, you stay outside, etc. These gadgets never existed when God created man and when eyes were created. So whenever a person is looking for near vision, there is a strain on the eye, and there is accommodation that happens because if you are focusing at a distance, your eyes are relaxed. When you are reading or when you are doing gadgets, your eyes are under strain, and there are the ciliary body and the ciliary muscles which change the elasticity of the lens, which causes a change in the power of the individual's lens. And that is what actually causes an increase. These are known to be myopogenic. That means that it increases the incidence of myopia. And there has been a sudden rush of children coming with myopia during the COVID, because everything went online and there were no examinations for them as regards going to school and seeing whether they can look at distance, etc., etc. So we have had an increase, I would say, of a percentage or 2% of people who need glasses in the younger age. If you look at East, you go towards Taiwan, Korea, Japan, 60% of them need glasses for myopia. So myopia is an epidemic or a pandemic, I would say, that's increasing disproportionately over the years because of the use of these gadgets. So the idea is that do gadgets or do near work or computers as much as it is essential in today's world. It's become almost a part of your life. So minimum time that you do there, and then you need to, when you're looking at a computer, you are not blinking properly. It's a semi-blink. So you need to open, close your eyes. Every 20 minutes, take a rest. You could do palming or this, and like about 20 times open and close your eyes so that the tear surfacing happens, and look at a distance of 20 feet for some time and just relax your muscles. So those are a couple of things. Exposure to sun, good outdoor activities, green leafy vegetables, those kind of things can happen. But these do not actually reverse myopia that has happened. Nowadays, there is a lot of work that is being done on myopia. So you have a simple thing, which is atropine drops in very low concentration that are being given at night to children for stopping the progression of myopia, because the accommodative spasm that I talked about, or the person accommodating, that muscles are relaxed because of atropine, and the progression of myopia has been known to get reduced with this. Plus, there are new types of lenses that have come for children, which have lenslets on the sides of the central vision is there, lenslets on the side, which stimulate the peripheral retina, which also is thought to be reducing the progress of myopia. So myopia is a big disease, I would say, and there is a lot of work that is being done to reduce myopia. But in case a person still has glasses and is after 21 years of age, his number is stable. There is the, again, which could be in the malls tomorrow, flap and zap, that you can go ahead and get a laser vision correction done and get rid of your glasses.
So what is the maximum age until when you can get your laser correction done?
There is no maximum age. I have done laser vision correction even for 70, 80 years, but that is post cataract, that if you have a refractive error, I have done that. But typically, as things stand today, when you are over 45 years of age, you tend to have different number for distance and different number for near. So laser vision correction, there are press beyond, etc., which is coming where you can do both near and distance correction, but that is still not that accurate. So you can correct basically the distance vision to large amount of accuracy. You may still need glasses for reading, but the laser vision correction is now merging with cataract surgery, similar procedure, which is called as clear lens extraction. That means that even though you don't have a cataract and you're 50 years of age, your quality of the lens proteins is going bad. You can now do the same surgery as a cataract surgery and replace it with a trifocal lens or a continuous range of vision lens, which can take care of your distance and near vision. So I would say when you are growing old, as better and better continuous range vision lenses are coming, it will go more towards a lens-based surgery rather than a refractive. So but you can get these corrective things done at any age. That's not a problem.
So you spoke about reversal, and you say
Yes.
it was not possible. But can children who get eyeglasses at a very early age, can they correct the eyesight with exercises and nutrition?
No, you can possibly try and see that these exercises have an effect on the progression of myopia to some extent, but reversal is not known with any medicines or drug, though there are some contact lenses that are being tried called as orthokeratology, which but that is a transient effect which changes the power of the cornea by changing the curvature and going about on that. But as things stand today, there is nothing to reverse the power of children, and the younger the person gets a minus number, the more chances of it going into high myopia and progression.
So my last question to you before I let you go.
Sure.
As an individual on the personal side, I mean, you are a busy doctor now. You have a responsibility to run an institution which has got many people working. Do you get time for yourself? And if you do, what is it that you enjoy doing in your free time?
So what I enjoy doing is work. Uh, and obviously, COVID had this thing, but I love to take short vacations, 4 days, 5 days, etc. Go out, listening to ghazals of somebody who died 10 years ago, Jagjit Singh, sitting by the beach side, not a fond swimmer, but doing that. And left, but would love to get back to playing bridge and maybe playing golf. But yes, I'm a sporty guy also, do like to do that. But traveling is something that I love, and listening to ghazals and being with old friends and remembering good old days is something that is there. So that's what I do. But yes, I do have a grueling 12 to 14 hours a day work schedule, and maybe 365 days because there are often conferences which take up our time on Saturdays, Sundays. But yes, short vacations, going mountains, going to Goa is another thing, music and sports.
So do you only listen to Jagjit Singh ghazals, or you also?
I am not a bathroom singer. Yeah.
Otherwise, I would have taken on to you and asked
No,
you to sing a ghazal.
no.
But Dr. Sachdev, it has been such a pleasure speaking to you, because this conversation was beyond just eye care. It was about the human aspect of how a medical professional can also run an institution and serve a larger set of people than restricting to just one single standalone clinic. It's been a beautiful conversation. Thank you so much for taking our time to be with us.
Totally my pleasure, and thanks, Harvinder, for just a great conversation that maybe hopefully should help inspire youngsters to do something more and come out of their comfort zone.
Absolutely, sir.